It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Thanks for listening to us. We have a few ultrasound courses coming up December 21st, January 11th in New York City, as well as online. If you're interested in training, check out the Virtual Pain Fellowship or Board Prep. Go to nrappain.org. Additionally, we now have an Android and iPhone app for NRAP Academy Pain Exam. You'll get CME credits. You'll be able to do it on the go, watch our videos, do our multiple choice questions, and much more. And I'm always looking for volunteers who are interested in getting their name out there and creating content. Additionally, I was honored to be invited to serve as a board member for the Latin American Pain Society, so I want to thank Sudhir Diwan for that. And I am looking forward to it. I believe it's in Chile next year, so that should be interesting. Never been there. And speaking of Sudhir Diwan, the New York, New Jersey Pain Congress is going to be next month in Jersey City. We also have other great conferences coming up, the Eastern Pain Association, followed by NANS, and much more. I will be announcing another regenerative pain medicine course, so just stay tuned for that. If you're not on my newsletter, please join at nrappain.org or painexam.com. And before I forget, there is a conference online from my good friend, colleague, Donna Coriel of SomiDocs, which some of you may know. She's got that huge Facebook group of physicians. And that's a pain conference that is going to be in June 6th to 8th. If you're interested in signing up, just go to nrappain.org, and you'll see the link to register. So that's going to be a lot of fun, and she's already got a lot of good speakers lined up with an interesting variety of topics. So, why are we here today? We're going to talk about multifidus atrophy because ever since the peripheral stim companies started to come about, and we've been doing these multifidus medial branch peripheral stimulators for patients who have axial back pain and multifidus atrophy on imaging, I've come to really appreciate this therapy, this problem, and it's really something that we know about, but we don't really always talk about as much as we probably could or should. So there's plenty of publications on the multifidus muscle. And I'm going to just review a few, try to give you guys a summarized overview of everything. And it has been shown that stenotic segments of the spinal canal are more atrophied in the muscle than the non-stenotic segments in patients who suffer from degenerative lumbar spinal stenosis. It shows that there's a strong positive correlation between the severity of the multifidus atrophy and the severity of spinal stenosis. So I guess when I hear something like that, it's chicken and egg. Which came first, right? What cause is the spinal stenosis causing the multifidus atrophy, or vice versa? Well, let's delve into this, shall we? And I'll have the reference I'm using on the show notes, so go check that out. So let's review lumbar spinal stenosis, which is an age-related condition with spinal canal narrowing due to degenerative changes of the facet joint. The degenerative narrowing of the spinal canal will induce compression of vascular structures and ischemia of the spinal nerves, leading to low back pain, leg pain, neurogenic claudication, disability, and loss of independence. And if you're in practice, I mean, some people listen to this podcast, they don't do pain, or you want to do pain, but if you're already doing pain management, or maybe if you have a grandma or grandfather and they're hunched over, this is a progressive disease that can really have a real horrible impact on a patient's life. I remember before I started doing milds and even before the spacers were out. I've seen patients who were too old for surgery, and my epidurals weren't working, and I really didn't have much else to offer them. And this is an awful disease. I mean, thank God we have more options for these patients. So there was a recent study showing up to 8% of adults aged 50 or older have degenerative lumbar spinal stenosis, and the incidence just increases with age. It's found on MRI in more than 20% of individuals over 60 years old, and symptoms are typically groin, hip, and buttock pain. There's a destructive impact on walking, moving independently, and the patients who are not moving around have other risk factors for pneumonia, DVTs, etc. So it's just not a good thing. Previous studies on the etiology and pathogenesis of degenerative lumbar spinal stenosis have focused on the degeneration of the three-joint complex with little attention to the role of the muscles. And the three-joint complex are the facet joints and the intervertebral disc that are involved in the spinal motion segment. Recent studies demonstrate that muscle atrophy is closely associated with degenerative lumbar spinal stenosis. It's the loss of muscle mass caused by immobility, aging, malnutrition, medication, injuries, or disease. It leads to muscle weakness, resulting in inability to perform physical tasks. Like degenerative lumbar spinal stenosis, muscle atrophy is another pathological condition prevalent in aged adults, highly associated with low back pain. Multifidus atrophy has been found in over 80% of patients with low back pain. Its severity correlates directly with low back pain symptoms. However, the linkage has not yet been determined. The correlation between multifidus atrophy and spinal stenosis remains poorly understood, and there are multiple studies studying the relationship between the two. They want to evaluate the correlation, because I got to tell you something. I'm reading this, and I'm practicing 17 years. I mean, intuitively, if you get spinal stenosis, it makes sense that if you're not moving properly, your muscles atrophy. But could it be the opposite? Could it be weak back muscles lead to the spinal stenosis? And I think there's a little interplay here. That's my guess. And just thinking out loud here, I have a patient whose spine, he doesn't really have much back pain usually. His spine looks like a disaster on the MRI. You wouldn't believe this guy's walking or has no pain. I mean, he did have back surgery in the past, and he's probably in his 60s now, but he's a surfer. And he tells me that when he doesn't surf, he has more back pain. And when he surfs, he has less back pain. So surfing, there's a lot of extension with that, and that's probably building up these muscles like the multifidus, interspinalis, and whatnot, and that's probably stabilizing his spine. So whenever I'm talking to patients about peripheral neuromodulation, there is something to be said about strengthening the multifidus muscle and stabilizing a spine. I mean, hey, that's why people do fusions, right? You don't want too much movement at an unstable or painful level, and that theoretically should reduce pain. Well, just getting good muscle tone is way better than fusion, right? So if you could do that for patients, I got to tell you, I've seen patients with those peripheral stim devices in the multifidus muscles that have gotten years of relief just from 1 2-month stimulation device or longer. So as you can guess, multifidus is super important here, right? So here in this article, they just looked at a lot of cases, retrospective study, and they were looking at 232 cases, MRI imaging diagnosing the spinal stenosis. The levels were L3, 4, L4, 5, and less at L5S1, which you could guess. Included patients with single segment central canal stenosis or lateral recess stenosis based on clinical manifestations. Imaging, multifidus atrophy, exclusion criteria, those with nerve root canal stenosis, lumbar, multi-level lumbar spinal stenosis, incomplete imaging or data, and previous fractures or surgery. They evaluated the multifidus cross-section at L3, 4, 4, 5, 5, 1, and then they graded the lumbar spinal stenosis, and then they handed the data to someone who does a lot of statistics I'm not going to get into. And they have some really nice pictures of spinal stenosis in this article. And they found stenotic segments have more atrophic multifidus muscles than non-stenotic segments, which, if you practice pain management, you kind of know already, so I'm not really blowing your mind here. But I think it's just important to establish this stuff because we do need to think about multifidus muscles now, especially now that we have a therapy to counteract the atrophy. And the severity correlates with the severity of spinal stenosis. Symptomatic sides have more atrophic muscles than contralateral sides. And there's some food for thought. I remember going to a conference in which the speaker, I believe it was probably NICE, it was regenerative medicine part of the conference, where they mentioned injecting PRP into the multifidus muscles reduced atrophy, reduced pain, and improved the appearance of the muscles. And I just found an article supporting this. I don't know if it's the same article the speaker wrote, but this is an article from 2016, way back. Effect of autologous platelet leukocyte-rich plasma injections on atrophied lumbar multifidus muscles in low back pain patients with monosegmental degenerative disc disease. They concluded after, and this is 115 patients, which, look, compared to cardiology, this is nothing. But in our pain management world, 115 is not too bad, right? I mean, we don't really have large, especially for regenerative medicine. Unfortunately, we don't have 10,000 patients that we're doing these studies on. I wish we did, but they put it into the atrophied lumbar muscles, and they concluded it was safe, effective for relieving low back pain with disability with long-term patient satisfaction and success rate of 71%. And they recommend leukocyte-rich PRP to treat the lower back pain. And here in the article, I think this is quite interesting how they did this. 70 to 85% of people we know experience low back pain at some point in their life. Multifidus has been proven to be an issue. I'm just paraphrasing here quickly. Atrophy of the paraspinal muscles occurs with chronic low back pain in monosegmental degenerative disc disease with reduction of the cross-sectional area at L4 and L5. And there really is no consensus regarding treatment of chronic low back pain. I remember back in 2007 at NYU when the protocols of low back pain were being discussed, and basically, I forgot which organization came up with the criteria. Basically, they left surgery out. The surgery wasn't even included in management of low back pain. And the surgeons threw a fit. Their societies, their lobbying organizations, whatever it was. So they got surgery back into it. But I don't have any set overall guidelines. I know they exist. I just don't have them here because they vary. And your treatment is going to be different depending on where you go. And there's evidence for so many things. I mean, there's evidence for magnets and lasers. So why is that not part of the algorithm for chronic back pain, right? So you can imagine I look at it just as an individual thing and just educate the patients and let them make their own decision. But back to this article, talking about surgery. As we know, surgery is controversial, right? The patient goes to one surgeon, says operate, another surgeon, don't operate, and many failures. When people ask me about surgery, I tell them straight up, I am biased. You're talking to a biased person, right? Most pain doctors are biased in the sense that we spend our day with people who've gone through surgery and are miserable. The good ones, the ones who succeed, don't come back to us. So 90% of people I meet who've had back surgery are miserable. That doesn't mean 90% of people who have back surgery are miserable. It just means the people I know, right? So I'm completely biased when it comes to back surgery. And if I send someone to a surgeon, 99% they need surgery. I'm not just sending people to surgeons so quickly just for the hell of it. Anyway, surgery could limit motion, increase stress on the adjacent segments, especially a fusion, right? And fusions have a high failure rate compared to many other procedures. It could be as high as 40%, and there could be non-union in 5 to 35% of patients. There's over 1,500 proteins with platelets, and among them are growth factors stored in platelets as granules, which are known to play an important role in the normal healing process. PDGF, VEGF, TGF beta, and much, much more. And if you want to find out more about PRP, come to one of my courses or do the online course I have at nrappain.org or in the virtual pain fellowship. It's all included. Anyway, leukocytes remove debris. They are phagocytotic. They secrete growth factors, and they have a role in balancing pro-inflammatory and anti-inflammatory aspects of healing, which has given me a little bit of a flashback to a previous podcast I did about leukocyte-rich PRP being recommended for intradiscal injections because there may be some infectious component of degenerative disc disease, which is another topic to discuss. I highly recommend you check out that article, and it's referenced in the podcast I did about that. It was done a few months ago. Just look it up. Anyway, there's no studies were done about the leukocyte-rich PRP into the atrophied muscles in patients with monosegmental lumbar disc degeneration, but they hypothesized that it may decrease chronic pain, improve disability, quality of life. So they included those with unilateral, bilateral, low back pain for at least 3 months with or without leg pain, below or above the knee, and moderate and severe lumbar multifidus muscle atrophy on the MRI, and one level degenerative disc disease without disc material extrusion in the canal. And they have some nice pictures here. They excluded changes of less than 10% muscle bulk, symptomatic spinal stenosis. Okay, so we're getting off the spinal stenosis topic here. Okay, they're just talking about the multifidus and back pain. They excluded disc herniation, spondylolisthesis, spondylolysis, scoliosis fracture. So they tried to really get a clean idea about these patients. So anyway, what did they find? Well, there were no complications, first of all, which is, thank God, something I've seen also with the PRP. It's super safe. Patients experienced some pain at the injection site for a day or two, very normal. It might even be more pain with the leukocytes involved because there's more. There could be extra inflammation, and I have nothing to prove that, just some anecdotal experience. And they analyzed all the data, and they concluded that the leukocyte-rich PRP can reduce the pain. And here they're saying that multifidus atrophy is a cause of back pain. So, with or without leg pain. And I'm always wondering, is it a cause or is it the result of low back pain and disuse? I see that they have a correlation here. I've yet to see here how they're actually saying it's the cause, because I would be really interested. I think it's a chicken and egg type situation here. Anyway, they saw a short-term reduction in pain after the injection, which I'm surprised that they're mentioning short, but they say that the platelet concentrates had an analgesic effect. There's a large amount of serotonin released from the dense granules of activated concentrated platelets at the injection site. So that's interesting. The serotonin released is what they're attributing to the pain relief, which is something that, and I do a lot of research in creating my courses and podcasts on learning as much as I can about the regenerative medicine field. I don't see many people talk about the serotonin, believe it or not. So they said the overall pain, disability, success rate, and satisfaction scores were statistically significant and reached a maximum between 12 and 18 months and remained stable throughout the follow-up period. Delayed clinical improvement can be explained by the time it needs for the paravertebral neuromuscular tissues to regain its biotensegrity, especially in the multifidus. So the limitation was there was no control groups, as well as the mention that paravertebral corticosteroids with or without local can also be performed in the vicinity of the nerve root, and even facet infiltration is a type of nerve root block which blocks the posterior branch when it emerges from the spinal nerve. And this can also create a iatrogenic denervation, increasing the lumbar multifidus muscle atrophy, as denervation leads to atrophy and increased muscular fat. Steroids will suppress inflammatory mediators, protein synthesis, suppress hypothalamic pituitary adrenocortical axis, and immunity, leading to severe infection. So they're reluctant to expose patients to steroids in return for temporary relief, and they consider it unethical. So listen, this is great for all those internists and people who are just injecting steroids into the muscles like it's nothing. It will give some temporary relief, but when patients ask me, "Oh, can you give me a shot today? Just put some steroid in my back or my butt," I usually don't. I tell them, first of all, I put steroid where it needs to be and hopefully nowhere else. And then in this day and age, I'm telling people standard of care is, what most people will do in a given situation is still the steroid shot, not because it's better, because it's reimbursed. The PRP is probably safer and better for you long term, but it's not reimbursed. And then I also look at the situation, right? My shoulder went out and I couldn't work. I had a corticosteroid injection, and within days I was back to functioning. That was an acute issue. But when I'm thinking what's best for me long term, I would say PRP 100%. It's just that PRP may not get me back to work within a day or two. So every situation is different. I think the standard of care should not be one particular procedure like medial branch block or facet block with steroid. The standard of care should be educate the patient as to the options, pros, cons, negatives, positives, everything, and of course reimbursement, non-reimbursement, and then let them decide. Once they're smart, they know how you're looking at the problem. Give them the options. That should be the standard of care. Standard of care should not just be one particular type of procedure for one particular problem. It should be education and explain to the patient what the options are. So anyway, they used the PRP, and they recommend that for treating chronic low back pain. And they're saying that, I never seen in a research article, and I'm going to give you guys the show notes, them say that it was unethical to put a steroid into the muscle. And I understand why they're saying it, right? If it's not the best treatment, it has more side effects and can possibly lead to muscle atrophy. Well, yeah, then it's not the right thing. The problem is insurance is not paying for PRP. So, and the reason for that is a whole nother discussion, and if you're into conspiracy theories or whatnot, that you can have a lot of fun with that. But anyway, between the PRP and the multifidus stimulation, we have two great options for chronic back pain associated with multifidus atrophy that is not yet mainstream, not yet even probably considered standard of care by most practitioners, but is probably superior care. So when I have a patient who has a positive MRI for multifidus atrophy, and let's say it's the issue is spinal stenosis with leg symptoms, well, I'll still probably offer them the epidural. If they fail that, a mild. But if it's mainly just a back issue, backache, well, then the discussion is, okay, let's try a medial branch block. Or if that's positive, well, we could do the traditional route, which is burning the nerve, which may lead to some more atrophy of your multifidus, which may or may not be clinically significant, but it's been done for like 50 years. It's standard of care. Or you do the multifidus stimulation, which could potentially cure your problem for years. Or you could do the PRP shot, which could also potentially cure your problem for years. So anyway, if you want to learn more about the regenerative medicine, go to nrappain.org, and you'll be able to sign up for the online course at the Virtual Pain Fellowship, or see me. Once again, I did not set a date for the next regenerative medicine course. It will probably be in May sometime. But if you have any questions or if you want private training, just reach out to me. My contact is on the website, or you could go to info@nrappain.org and shoot me an email. I do on-site training. You could come to my practice, or I could come to yours, depending on your situation, or just come to one of my courses or train online. Thanks for listening. Please rate, review the podcast, as well as share it with your colleagues. I appreciate you. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.